Joshi, Senior Cataract Surgeon and Phaco Trainer at Amita Eye Care Tiruvalla, for the talk Tips to Conquer Surgeons' Initial Challenges with Grace. Over to you, Dr. Aditya.
Good morning, everybody. I would like to thank KSOS Organizing Committee and Dr. Raki for giving me this opportunity to present this talk over here. I'll be talking about the challenges what a beginner gets during his training time. Like I was also a beginner at some point of time, and I used to face all these challenges. But I was fortunate enough to have Amita madam and Varghese sir with me, who taught me all these things. So let me share all those experiences with you. No financial interest. I'll be talking upon these points: clear corneal incision making, sculpting, chopping techniques, the phaco-dynamics of sculpting and chopping, dynamics of quadrant removal, epinuclear removal. So before a surgeon comes to a actual case or on a human eye, he should have a very good wet lab practice, as everybody told earlier. He should know all these things like IPD. He should know his microscope, what he is going to use, the foot switch. A good posture for the surgery is also very important. As a beginner, we should always give a good, adequate local anesthesia so that you can perform your surgery most efficiently and with a calm. Know your phaco machine well, know the phaco dynamics, and as told earlier by all the speakers, that record and always assess all your surgical videos with your seniors. So I'll go step by step. First is the corneal incision making, the clear corneal. As you can see over here, the beginner is trying to make the clear corneal incision, but the globe is little softer and the hold with the left hand is not that good. So the globe is rotating to the other side and the surgeon fails to make a clear corneal incision over here. So what we can do is fix the globe very well. Chamber should be tight, and with a sharp keratome, it should be a ideal 3-planar or a biplanar incision. You can say the surgeon goes in the inner incision, there is a dimple what we have to create. Go inside straight and come out in the same fashion without extending the incision elsewhere. Next step is hydrodissection. First we need to remove whatever the extra viscoelastic is there in the anterior chamber. Then go underneath the anterior capsule, lift up the anterior capsule and then inject the fluid without forcing it. It should be a gentle procedure. Sculpting. For sculpting, what we need to do mainly is get rid of the central hard core of the nucleus. So the power should be more, but vacuum and flow rate are bare minimum, because we don't want any holding over here. We just want to get rid of the hard part of the nucleus. When we trench, the angle of attack of the phaco tip or the direction in which we trench should be according to the contour of the nucleus. The nucleus is deepest at its center, and in periphery it's quite shallower. So if we trench deeper in the periphery, there is a good chance that we will hit the PC and get a rent at this point of time itself. But if we don't trench in the center well, we will have a harder portion of the nucleus remaining in the center, which may not crack, and we will have an inappropriate crack. Again, when we crack the nucleus, the instrument should lie as deep as possible on the floor of the trench. Then only the crack will be better. If you are anterior, the crack will be halfway, or it will cause more stress on the zonules. So this is how the cracking should be. For chopping, you can see over here a surgeon is trying to get a hold into the substance. He tries to get a buildup of vacuum, and even the chopper here you can see doesn't go till the depth of the nucleus, and hence the chop is not coming very well. Somehow the surgeon gets a separation, but it's not all the way through. So what he does next, he goes to another part of the nucleus, tries to get a hold, but the phaco energy used here was additional as compared to what the density of the nucleus was, and finally ends up eating up the piece rather than getting a good hold. He goes to another area of the nucleus to get a hold, but this time he loses its foot switch control, and by the time he tries to hold and get it into the anterior chamber, the piece is lost again back into the bag. So what to do? Here you can see a better holding pattern, but the phaco tip is not totally buried into the substance, and even the chopper you can see the tip of the chopper. That means it is obliquely held. It is not reaching the depth well. That's why the chop did not happen well. So what to do? You have to dig deeper into the substance of the nucleus. The chopper should be lying vertically oriented. It should go all across the depth of the nucleus, and then you can get a good horizontal chop like this. It's better to use a burst mode for chopping with a high vacuum settings like 300 to 400 mm of Hg and a flow rate of around 30. For quadrant removal, as we see, first we have to separate the pieces either by a horizontal or a vertical chopping, or do a divide and conquer. And once we get the separate pieces, we should go to the depth of the cone of that quadrant, in say around 2/3 depth. Get a good hold. Once there is occlusion sound, get the that means the vacuum is developed. Get the piece into the pupillary plane and then release the full energy, so that with the followability, with your good flow rate, the piece should come out, get emulsified. So for quadrant removal, what we need more is a vacuum and a good flow rate. For epinucleus removal, what we need is minimum phaco energy, but more of vacuum and flow rate. So just go closer to the epinucleus area, which should be free and not attached to the surrounding bag or the cortical area. It should be free. If a good hydrodissection is done, we will have a better epinuclear clearance. So this is how the epinucleus clearance should be done. For cortical aspiration, it's most important, because after doing a good surgery, if we get a PC rent at this point of time, it's too bad. So what we should have is a irrigation. As you can see, the two irrigating ports are on sides horizontally, but the aspiration port is facing upwards towards the endothelium. Go under the anterior capsule, under the cortex, get a good hold, get the piece back into the anterior chamber, and better to aspirate the cortical matter into the anterior chamber rather than aspirating it closer to the bag or closer to the PC, because a surge at this point of time can cause a rent again. So the message is surgery is both science and art. So learn the basics of basic science of surgery, and you can then develop your own art of doing it. Do not get panicked or depressed by any complications. Stay calm, reassess your videos, and then later on you can rectify your mistakes, so that you don't do them again. Doing basics right will boost your confidence, and then you can accept more and more surgical challenges in future. Thank you.
Thank you, Dr. Aditya. That was great videos and great tips from you.